A cup of coffee in the morning is a necessity. As you can see here, Einstein was just an ordinary man without a cup of coffee in the morning. Well, this is going to be my final case presentation on Paraneoplastic Pemphigus. This patient was a 78-year-old gentleman who was a dentist. His son, who's also a dentist, brought him to our clinic because of the multiple painful blisters and ulcerations all over his mouth and lips. This all began about a year before he presented to our clinic, and he was also getting erythematous patch along his forearms. Oral blisters were extremely painful, 5 to 7 out of 10 baseline pain, with increase to 9 out of 10 on function. These photos were taken on his first visit to our clinic. His entire dorsal tongue was blistered, ulcerated, and covered with fibrinogenous membrane. Bilateral buccal mucosa and his lips showed similar findings. His soft palate and his throat were less involved. And these are his arms showing erythematous patches all over his arms. This is his past medical history. He was diagnosed with lymphoma of not elsewhere classified, malignant, and unspecific primary site. He was initially treated with radiation therapy in 1991, but recurrence was found in 2006, which was treated with chemoradiation. And finally, he had another recurrence and had chemotherapy in 2009. PET scan he had in mid-2010 showed 100% remission. He had history of MRSA infection in his replaced knee, which he still goes to physical therapy, but otherwise it's well controlled, the infection. Benign prostate hypertrophy is common in this age group, and also he had atrial fibrillation, hypertension, GERD, and anemia. He was on various medications, but there were no drug-and-drug interactions, and no medications were started in proximity to the onset of his condition. These are the workups done for him before he came to our clinic, and they were basically done by a dermatologist. He had skin biopsy done, which was suggestive of erythema multiforme. Then he also had lip biopsy done, which was suggestive of lichenoid mucositis. Skin direct immunofluorescence was performed, which did not show any deposition of IgG, IgM, IgA, or C3. Serum IgG was not elevated. Antidesmoglein 1 and antidesmoglein 3 were within normal limits. Our clinical diagnosis for him was paraneoplastic pemphigus. Graft versus host disease, erythema multiforme, Stevens-Johnson syndrome, and toxic epidermal necrolysis were in our differentials. However, they were all unlikely because his knee replacement was back in 2006, and no new medications were started in proximity to an onset of his condition. So what we did for this patient was, first we contacted his dermatologist and asked to dose up on his corticosteroid up to 60 milligrams because he was only taking 20 milligrams right now. Decadron elixir and Miselex was additionally prescribed, and asked him to come back in 3 weeks to see progress. However, unfortunately, he didn't have much improvement after 3 weeks. So what we did at that point is, first we asked the patient to consult or go back to his oncologist for follow-up, because we suspected possible recurrence of his neoplasm, or there may have been a new neoplasm that is still not yet detected. So, what is paraneoplastic pemphigus? It is a life-threatening condition with high mortality and also very, very difficult condition to manage. Paraneoplastic pemphigus was first described by Anhalt in 1990 with the case series, which is quite recent. From then, about 250 cases are reported. Average onset of this condition is estimated to be about 51 years old, but with very wide range of onset, ranging from 7, the youngest, and 88, the oldest. Most commonly, it occurs in association with lymphoproliferative neoplasms, but not limited to these. It has very high mortality rate, one from neoplasm and secondary from infection from epidermal blistering and ulcerations. The most commonly associated neoplasm with paraneoplastic pemphigus is non-Hodgkin's lymphoma, which accounts for about 39% of all condition. Chronic lymphocytic leukemia and Castleman disease follow non-Hodgkin's lymphoma by 18.4%. Other carcinomas and sarcomas, such as breast cancer, basal cell carcinoma, prostate cancer, liposarcomas, leiomyosarcomas, etc., are also reported in some cases of paraneoplastic pemphigus. Castleman disease is the only benign neoplasm associated with paraneoplastic pemphigus, which is basically an overgrowth or proliferation of lymphatic cells. The younger end of paraneoplastic pemphigus cases are mostly associated with this condition. Recently published article by Leger gave a good number of paraneoplastic pemphigus association with known or unknown neoplasm. He reported that only 68% of paraneoplastic pemphigus cases had already diagnosed neoplasm, and 15% had concomitant discovery of neoplasm with paraneoplastic pemphigus, and 17% of neoplasms were discovered after the onset of paraneoplastic pemphigus. Clinical presentation of paraneoplastic pemphigus widely varies and now appreciated as spectrum of the same condition. They generally involve painful mucosal and skin lesions, which may be bullous or erythematous patch or papule. One of the characteristics of paraneoplastic pemphigus is that blisters in paraneoplastic pemphigus do not arise from normal skin, but typically develop from inflammatory papules or macules. They may also involve internal organs such as lungs, thyroid, kidney, smooth muscles, and GI tract. So, the new term paraneoplastic autoimmune multi-organ syndrome, or PAMS, has been addressed. It may present pemphigus-like, graft versus host-like, erythema multiforme-like, or lichen planus-like, depending on where it falls in the spectrum of the disease. And the list exactly look like our differential diagnosis for our case. Because it is relatively new and also a very rare condition, there's still no definitive criteria for diagnosis of paraneoplastic pemphigus. There are 3 proposed criteria which are shown in this table. They mostly base on clinical findings, histopathology, direct immunofluorescence, indirect immunofluorescence, circulating antibodies, and presence of a neoplasm. They seem to have different opinions on which criteria is more important than the others. One of the challenging part of diagnosis of paraneoplastic pemphigus is that tests we normally do for other vesiculobulous conditions may not have high sensitivity for paraneoplastic pemphigus. Jolie et al. Reported only 41% sensitivity for direct immunofluorescence and only 51% sensitivity of suprabasal acantholysis on H&E stain, which is a histopathological examination. Only 45% was positive for erythema multiforme or lichen planus-like oral histopathological findings. Surprisingly, only 9 out of 22 biopsy specimens of paraneoplastic pemphigus showed deposition of IgG and or C3, which is consistent with what our patient had. He didn't have deposition of IgG and C3 on direct immunofluorescence of the skin biopsy. What actually has high sensitivity and specificity for paraneoplastic pemphigus is detection of serum endoplakin and or periplakin, and also indirect immunofluorescence of rat bladder. So in paraneoplastic pemphigus case, indirect immunofluorescence is actually better or has higher sensitivity and specificity compared to direct immunofluorescence. Normally for other vesiculobulous disease, direct immunofluorescence is the gold standard for diagnosing the condition, and indirect immunofluorescence normally has lower sensitivity and specificity. But in paraneoplastic pemphigus, it's the opposite. Also, patient with diagnosed lymphoproliferative disorders had a higher sensitivity, meaning that if they have a history and they are presented with the severe skin and oral conditions, that it is more likely to be paraneoplastic pemphigus. Pathophysiology of paraneoplastic pemphigus is still yet unknown. There are 5 broad categories of hypotheses which explain the pathophysiology of paraneoplastic pemphigus. Epitope spreading is the tumor cell inducing a cell-mediated lichenoid interface dermatitis that uncovers previously hidden antigens. Antigen mimicry is a humoral immune response against the tumor cross-reacting with normal epithelial proteins. Cytotoxicity is an autoreactive cellular cytotoxicity mediated by cytotoxic T cells, natural killer cells, and macrophages. Autoantibodies, a production of autoantibodies reacting to epidermal proteins by the cells from the associated tumors. Interleukin-6 is just a dysregulation of cytokine production by tumor cells with secretion of massive amounts of interleukin. So, simply put, in a diagram, I would say it's like this. This is a human with a neoplasm. Either your own immune cells reacting with this tumor is also destroying your skin, or this tumor cell producing some hormones, enzymes, cytokines that is destroying your tissue. Management of paraneoplastic pemphigus is extremely difficult, basically due to an incomplete knowledge of the pathogenesis. But the basic concept of management is first to stabilize the patient and then look for underlying neoplasm and treat it. Paraneoplastic pemphigus is managed with either immunosuppression, immunomodulation, or removal of pathogenic autoantibodies. These are the list of medications. Those have been tried to manage paraneoplastic pemphigus. As you can see, these are all immunosuppressants or immunomodulators, except for IVIG and plasmapheresis, which work on diluting or removing abnormally functioning antibodies. In any of these medications, oral lesion is the toughest to treat. So it is said that it's first to come and the last to go. Most of these medications have good benefit or good outcome in cutaneous lesions, but not the oral lesions. The medication that seems to be promising for both cutaneous and oral lesions is Rituximab, which works well on both original neoplasm, which is lymphoma, and also for paraneoplastic pemphigus. This is actually what we recommended the patient to have after discussing with his oncologist. Our patient went back to an oncologist and he was found that he has mild recurrence of lymphoma. After discussing with the oncologist, they agreed to try therapy with Rituximab. I haven't seen the patient after he was put on Rituximab, but his son sent me an email saying that his father is complaining less about his oral pain and now asking more of vegetables for food, which is a good sign because he had been refusing to eat vegetables because they are causing extreme pain in his mouth because of the ulcerations. The other thing we could have tried for the patient is the topical tacrolimus, which seemed to be beneficial in few cases that was reported for oral conditions. Well, I guess that's it. Now that I'm done with all the case presentations, I think it's time for me to go to a beach. Thank you.